Acute pancreatitis is an acute inflammatory condition of the pancreas caused by premature activation of digestive enzymes within the gland itself. In this video, we'll cover the causes, pathophysiology, clinical presentation, diagnosis, complications, and management. The two most common causes of acute pancreatitis are gallstones and alcohol. Gallstones can obstruct the pancreatic duct, while alcohol can directly injure pancreatic acinar cells. Other causes include hypertriglyceridemia, hypercalcemia, ERCP procedures, trauma, and certain medications. When a gallstone becomes lodged near the ampulla of Vata, pancreatic secretions can no longer flow normally into the duodenum. This obstruction causes digestive enzymes to accumulate and become activated within the pancreas, initiating inflammation and tissue injury. Normally, pancreatic enzymes are inactive until they reach the small intestine. In acute pancreatitis, these enzymes become activated prematurely inside the pancreas. As a result, the pancreas begins digesting itself, a process known as autodigestion. This triggers a powerful inflammatory response that may extend beyond the pancreas. Patients typically present with sudden severe epigastric pain that often radiates to the back. The pain is frequently associated with nausea and vomiting. Many patients describe the pain as constant and intense, and it may worsen after eating. Lipase is the preferred laboratory marker because it is more sensitive and specific than amylase. CRP is often elevated and can help assess disease severity. Calcium levels may fall due to fat necrosis, while liver function tests may be elevated when gallstones are the underlying cause. The diagnosis of acute pancreatitis requires at least 2 of 3 criteria. First, characteristic abdominal pain. Second, elevated lipase or amylase levels greater than 3 times the upper limit of normal. Third, imaging findings consistent with pancreatitis on ultrasound, CT, or MRI. Acute pancreatitis can lead to several local complications. These include pancreatic necrosis, pseudocyst formation, and infected pancreatic collections. Such complications may require prolonged monitoring and, in some cases, intervention. Severe pancreatitis may trigger a systemic inflammatory response syndrome. This can result in acute respiratory distress syndrome, acute kidney injury, hypotension, and shock. These complications are associated with increased morbidity and mortality. Management begins with an ABCDE assessment and supportive care. Early intravenous fluid resuscitation is essential to maintain organ perfusion. Treatment also includes adequate pain control, antiemetics, nutritional support, and management of the underlying cause. In gallstone pancreatitis, ERCP may be required. To summarize, gallstones and alcohol are the most common causes of acute pancreatitis. Lipase is preferred over amylase for diagnosis. Hypocalcemia may occur due to fat necrosis. Diagnosis requires 2 of 3 standard criteria, and early fluid resuscitation remains one of the most important aspects of management.